Welcome all. It's a pleasure to be here with the AASD meeting. It's a very prestigious meeting, and us as cardiologists have always been on the front with the diabetologist and internal medicine in the treatment of diabetes mellitus. Today's presentation will be talking about diabetes mellitus and heart failure. What is up? Well, actually, as we know, diabetes mellitus is a very debilitating disease with multiple impacts on cardiovascular endpoints. And management of diabetes was always associated with the reduction of blood sugar. There are conflicting data on cardiovascular outcomes that we will discuss. And nowadays, in cardiology and other specialties, heart failure has emerged as one of the biggest medical and economic burdens and a focus point on cardiovascular disease. Why is that? Because around 1% of the population in the world has heart failure. Not only that, it entails a big mortality on the patients all over, even if they are discharged, and rehospitalization even is quite high. If you look around the world, it's an average of 1% of the total population. Not only that, there is always a decline in the quality of life of a heart failure patient. And sometimes there's acute exacerbations with acute episodes, heart failure hospitalization, and all of these progress to mortality. Another important problem with heart failure is its economic burden. And economic burden of heart failure hospitalization is the biggest single economic burden in any health insurance initiative. Not only is hospitalization costly, but it's costly also for mortality and morbidity. And those who are hospitalized more frequently have a 2.5 times increased risk of mortality. And this goes with the second, third, and fourth hospitalization. Mortality is increased in recurrent hospitalization. So what is the goal of care in heart failure? What we want to prevent, if it's possible. That's it, manage the risk factors, well, like diabetes, hypertension, ischemic heart disease, and also manage them even if the patient has heart failure. Reduce death and hospitalization, and improve the quality of life, which is the most important to improve the patient's everyday life. We know in diabetes, the mortality is quite higher than other diseases. Those with diabetes and a myocardial infarction actually have a life expectancy of minus 12 years than expected. Those with diabetes by itself has a life expectancy of minus 6 years. So it's not something to be taken very lightly. And heart failure in diabetes actually was a very common finding, even more commoner than a myocardial infarction or stroke. So heart failure is quite an important entity in diabetic patients. And diabetes leads to heart failure in two different mechanisms: through ischemic heart disease, which is atherosclerotic dependent mechanism, and other mechanisms which are atherosclerotic independent related to the inflammation, the malfunction of the myocardial cells, and thus dilatation and heart failure. So two mechanisms that are either atherosclerotic dependent or atherosclerotic independent. And if you look at data from several registries, actually more than 2/3 of diabetic patients actually have some sort of LV or left ventricular dysfunction, be it systolic, be it diastolic, or be it a combined. And we should know that heart failure, which is heart failure with reduced ejection fraction, which is an ejection fraction below 40, is the one we think about, but there is also another entity, which is heart failure with a preserved ejection fraction above 50, and this is a very common and very intriguing heart failure nowadays. So, does glucose lowering have a benefit on heart failure? Actually, no. If you look at the data from the different trials, glycemic control does not really improve or benefit for the prevention of heart failure. And actually, we have a dilemma of data on how many heart failure patients were included in the cardiovascular outcome trials. Here, I'm just showing the DPP-4 and GLP-1 receptor agonists. You can see there is a heterogeneity in the amount of heart failure patients included. And actually, if you look at the data for DPP-4 and GLP-1, actually there was no big benefit. There was a reduction of benefit. In fact, it was a rather hazardous medication that was saxagliptin in the SAVOR TIMI-53. And of course, at the bottom, you can see that the TZD's pioglitazone, of course, rosiglitazone has been suspended. They increase the incidence of heart failure quite a little bit. So heart failure is an important entity in any diabetic patient. So the hospitalization as seen in different event rates in the patients taking either insulin, DPP-4 or GLP-1 receptor agonist is quite heterogeneous. The only really contraindicated medication was saxagliptin seen in the SAVOR TIMI-53, but there is data that is actually not in favor of any of these medications that will improve the heart failure hospitalization. So we have key unmet needs in heart failure. There is still a high mortality. The mortality in heart failure with a reduced ejection fraction is still as equal as that of some cancers. So came the sodium glucose cotransporter inhibitors. They inhibit glucose and sodium reabsorption in the proximal tubule. Thus, there is an increase in urinary glucose excretion, some natriuresis and some osmotic diuresis. But can they benefit the heart? Well, actually, there are three postulations. The diuresis with glucose excretion and natriuresis. This might improve the cardiac function, decreasing the preload and afterload. Thus, the feedback mechanism is less. Thus, the sympathetic and renin-angiotensin-aldosterone system effect is less. There is also a decrease in the edema, a decrease in weight, improvement of the left ventricular mass, and increase or improvement of the kidney function. So if you look at the three things, the glucose and the sodium and the volume, they can have a lot of mechanisms improving the function of the cardiovascular system, thus reducing the effect of heart failure. And this just sums it up. They do natriuresis, they reduce the preload and afterload, thus increasing the reduction in the left ventricular wall stress, reduction in interstitial edema with improved cardiovascular function through the kidney and improved kidney function. And if you look at their cardiovascular outcomes, there was a reduction in heart failure hospitalization, which was consistent with empagliflozin, canagliflozin, and dapagliflozin. Maybe cardiovascular death was only significant in the empagliflozin arm, but the 3-point MACE was met also in the empagliflozin and CANVAS program. But it is consistent. Heart failure hospitalization was reduced on average 31% in the three data of cardiovascular outcome studies. And this was consistent whether the patient had multiple risk factors or established cardiovascular disease. This was also consistent if the patient had prior heart failure or no prior heart failure in the three studies. Thus, a very consistent data, which is very important. Looking also to real-world data, not only the cardiovascular outcome studies, we can see from CVD real studies that this was also consistent around a 36 to a 39% reduction in heart failure hospitalization according to the CVD real 1 and the CVD real 2. Thus, these medications actually reduce heart failure hospitalization, whether in the cardiovascular outcome studies or also in the real world studies. So let's take a look what's going on. We had a minority of patients with heart failure in the cardiovascular outcome studies, and this has shown us that there was a reduction of heart failure hospitalization. Of course, heart failure is not a single entity, and we have a lot of different phenotypes. But we really required another important thing. We really required dedicated heart failure studies, randomized control studies on heart failure, especially with the reduced and preserved that are required. And this would be the most important part to indicate SGLT2 inhibitors in heart failure. It started off last September in 2019 with dapagliflozin's outcome in the DAPA heart failure study, and here it is published in the New England Journal of Medicine. There was a significant reduction in the primary endpoint of cardiovascular death, heart failure hospitalization, or an urgent heart failure visit. You can see the p-value, highly significant versus a placebo. This is very important. You can see the worsening heart failure event was also significantly reduced in dapagliflozin versus placebo. This was all in cases of heart failure with a reduced ejection fraction. And this year, in September 2020, the data from Emperor reduced, again, a heart failure randomized control study in those with heart failure with a reduced ejection fraction came out, and it showed a reduction similar to dapagliflozin. There was a reduction in the primary outcome, heart failure hospitalization, not a reduction in cardiovascular death, but it was consistent. The reduction was very significant. And this was seen also in the reduction of recurrent or first hospitalization for heart failure, an incredible reduction seen with empagliflozin versus placebo or the standard of care. Of course, in the empagliflozin arm here, in the Emperor reduced, there was an 18% of patients taking even the best standard of care, which is the angiotensin receptor neprilysin inhibitor sacubitril valsartan, while it was only 11% in the DAPA heart failure study. So again, on top of the best medications, these two studies show us that SGLT2 inhibitors not only prevent heart failure, but they can treat heart failure and improve outcomes. This was seen also with better outcomes in diabetics or non-diabetics. This was in the Emperor reduced, and this was the DAPA heart failure. Any patient, diabetic or non-diabetic, showed this. But of course, you might be thinking, this could be a better medication when added to other meds, but is it safe? And this was another important question. Actually, it was extremely safe. The incidence of any side effect or adverse event was quite neutral. Number two, the incidence of UTIs or renal adverse events were reduced, actually, not significantly in the DAPA heart failure, but significantly in the Emperor reduced. But diabetic ketoacidosis in both was really good. The incidence of hypoglycemia in the non-diabetics was non-significant. There was no reduction in blood sugar. So this shows not only the superiority, they can be used in heart failure with a reduced ejection fraction, but also their safety. So if we talk about heart failure with a reduced ejection fraction in diabetes, we have the RAS system inhibitors, headed now by the ARNI, the beta blockers that inhibit the sympathetic nervous system, the aldosterone antagonist, and actually not all SGLT2 inhibitors. It's dapagliflozin and empagliflozin. So we've been shifting from a preclinical stage of the disease where there is prevention to now treatment of the established heart failure as seen in DAPA heart failure and Emperor reduced. We're still waiting for those with preserved ejection fraction, the DELIVER and the Emperor preserved, and this will be seen next year, hopefully. But the question comes, is the cardiologist important in the decision here, or is it only the diabetologist? Well, heart failure is a complex disease that can pass unnoticed. Even us cardiologists might even not find it. And it is a subspecialty that we should be always managing with it. And up titration of the medications and omitting and adding others is really seen by the cardiologist more. And when the patient is hospitalized, it is in the CCU. That's where our work is. And these medications, as you just saw, do not lower the blood sugar excessively or do not cause significant hypoglycemia. Thus, the scale of hypoglycemia, which is hazardous, is quite low. So, us cardiologists should know the indications, contraindications, but diabetologists are always a cornerstone of the treatment of the diabetic disease. So actually, we can say that SGLT2s are cardiorenal protection medications with a glucose lowering capability. And that's why in the ESC guidelines, they were up titrated very high, them with a GLP-1 receptor agonist as initial therapy for those at high or very high risk. So to take home, heart failure is a huge problem, accounts for the greatest amount of hospitalization and economic burden. Diabetics have an increase in incidence of heart failure, and we saw around 2/3 of diabetics do have a problem of heart failure. Reduction of hospitalization, improvement of symptoms is a cornerstone of managing of these patients. And anti-diabetic medications that were tested for cardiovascular safety in the EMPA-REG in 2016, empagliflozin showed this cardiovascular benefit, but the consistency of these heart failure hospitalization reductions was seen in the other cardiovascular outcome studies. And now with DAPA heart failure, Emperor reduced, we can see that these medications are not only beneficial for the heart, but also for the kidney, and are going to be a cornerstone for managing heart failure in diabetics and non-diabetics. And thank you.